I would just like Dr. Shobini to sort of take center stage and talk to us about the importance of serving such a large population that has gone unserved, and how one can develop these sort of modules and ensure that the medical professionals of India are equipped to handle the wave of change that's on its way. So, Dr. Shobini, if you could please.
So thanks, Tia. And I'm really happy to be here, primarily because even I'm a Hardonian, and it's great to be back here, though virtually. The other thing I'd like to say is that I'm out of town and in rural Maharashtra, so forgive me if there are audio disturbances. Now, the question that you asked was, how does the work that NACO does kind of figure with gender-friendly healthcare? So, since I represent NACO, NACO is a division of the Ministry of Health and is responsible for the country's AIDS response. Now, in the AIDS response, considering the sexual transmission of HIV, there have always been targeted interventions around populations that we, name as high-risk groups or HRGs. Now, high-risk groups traditionally that we worked with include female sex workers, men having sex with men, injecting drug users, and transgendered communities. And of course, we do understand that some of these high-risk groups that we call could be part of the larger population of LGBTQIA+. But in the HIV program, we continue to use the terminology of key populations or high-risk group individuals. Now, the HIV prevalence among the transgender or Hijra population in India is as high as 3.14%, as against a general population prevalence of 0.22. And this is much higher, and which is why we kind of have been working. Now, the modality of how NACO works with populations is through community-led and community-centric approaches. So, as against many other health programs, the program of HIV always has a very, let us say, strong connect and engagement with community. And to a large extent, even the community reaches out to NACO for needs beyond their HIV/AIDS needs, so to say. So, like in the HIV/AIDS spectrum, we provide services like access to condom or access to knowledge and information about HIV prevention, about accessing an HIV test or access antiretroviral treatment if a person were to be found positive. But people do reach out to us to link them to hormone therapies or for gender reassignment, or what is now known more as gender affirmative procedures and surgeries. So because of this, there are actually two instances why NACO got kind of pulled into activities beyond their total mandate. One is that there was a very strong interest under the Niti Aayog. They created a subgroup for LGBTQIA and asked various ministries to look into holistic needs. So not just health needs, but holistic needs. And there were responses and meetings to be attended. And in the ministry, the matter traveled all across. It went to perhaps the medical education, it went to hospital division, and then it came to NACO because nobody else in the ministry seemed to know how to engage with communities. So, and similarly, there was the National Human Rights Commission had also conducted a conference. And as part of that conference, they had also indicated many asks of different ministries. So the asks from Ministry of Health were again marked down to NACO. And I'll just like to tell the group about the three major asks, which are probably one of the reasons and a kind of background behind this kind of interest getting generated, not only across the medical profession, but also across young professionals like Querencia and even other community support groups as well. One is that there is a definite need for strengthening medical education in this area. So be it about, transgender person might come to a hospital for just a stomachache, but the way he's treated, the way he's talked to, and the way he's even addressed to, knowing about what people's preferred pronouns are. Those are things that medical school does not teach. So we need to have this medical education part really ramped up. And I'm happy that we have representation from Indian Academy of Pediatrics and many senior stalwarts who will be able to make that much needed change in undergraduate and postgraduate curricula. The second thing is services. So services for gender affirmation are far and in between. They are available in niche settings for which a person really needs to know where he wants to go to get what he needs. And the fact that it is a need and it is not something like cosmetic surgery or something like, some kind of plastic surgery that a person wants just to beautify himself, it is actually to express his identity. And that clarity needs to be worked out. And perhaps the idea that Athi had about setting up centers of excellence, in which we are trying to, we have written to All India Institute of Medical Sciences to open such a gender affirmative clinic. And the third most important thing is that we start having a sort of inclusive atmosphere free of stigma and discrimination across board. So this will mean sensitizing a huge array of healthcare, not only doctors, but healthcare workers in how to talk to people. Like there are people who come to us and say, but why is there not a toilet for me in a hospital? Or why is there not a queue where, I can stand? I don't want to stand in the women's queue or the men's queue. So where do I stand? So these kind of things. And even the clarity, the clarity between what is gender identity and what is sexual orientation. There is, even that gingerbread man is not either taught, and it is not something that is understood in the medical profession per se. So by being in NACO, we kind of get inducted into it because of the community engagement, but it requires mainstreaming and it requires to be all there. So I think, Thea, I hope I kind of tried to answer what you had asked. So while it may begin with the HIV program, we can't expect to confine it there, and it has to be owned by many more people to move further.